Welcome, Dr. Lee. Testing 1, 2, testing 1, 2. Hello, Juha. Hello.
Hello, John. Hello,
How you
Tom.
doing?
Fine,
Yeah.
fine.
Yeah, we got everything straightened out.
Yeah, it's good. Yeah.
Yeah, sometimes I make a mistake, and I picked the wrong banner.
Mhm.
But most of the time
Tell
I
them.
got it, most of the time I got it right anyways.
That's right.
We're okay. Dr. Lanzino was here. I think he wanted to say hi. He may have stepped away. He said he's going to write you an email. So, okay, Ewa?
I didn't catch it.
Oh, Dr. Lanzino is going to write you an email.
Oh, okay, okay.
Okay. Okay, I'll be back. We got about 12 minutes.
Yeah, yeah.
Got to make sure Ben comes in here. Oops, gotta mute that so you don't hear that.
Hello, Professor Yua.
Hello, Abdi. Hello. Nice to meet you.
Nice to meet you. John?
Yeah.
No, I'm looking for John.
Yeah, I
Oh,
tell you,
okay.
hey, Abby, I tell you, the king was in a tizzy.
Send the wrong brochure.
I tell you, when the king's in a tizzy, the palace is in an uproar. Oh, the king's upset. The king's upset. I just made a mistake. I made a mistake with one of the blasts. Put the last week's webinar in. So, anyways, it's all straightened out. Ms. Takashi. Good morning, Harshad.
Good morning, John. Good morning, Professor Juha.
Hello, Harshad.
How are you?
Fine, fine.
Great to see you once again.
Thank you. Thank you.
Well,
Thank
the king has arrived.
Yes, Professor Goel is
Hello,
there.
Atul.
Let's see if he's still on a tizzy, Abby.
You are
Hi.
evening. You are.
Yeah, we got that
Hello,
straight.
Atul. Hello,
Yes.
Atul.
How are you? How are you? You are.
Good evening.
Fine. Thank you.
Ben is there.
Not yet. I wrote him a couple of
Hey,
emails to make sure.
Good evening.
Good evening,
Rakesh.
Takashi.
Takashi, how are you?
I'm fine. A little colder these days.
Okay. You are. You are.
Yeah, Atul.
I'm going to take you to craniovertebral junction today. Okay.
Yeah. We have spread the message.
Junction.
Yeah, spread the message. Yeah.
So different for you. I know you are not very interested in this subject, but let's enjoy.
I have done everything in my life.
You've done a lot of those, Juha? You've done a lot of craniovertebral cases?
Of course, in a small country, you don't have that amount.
Oh, okay.
But
You do everything.
Hi, Atul.
Hi, Harshad. How are you?
I'm good. Good to see you every day. Nowadays, I'm seeing you at least on the web.
He's everywhere.
Good to see you.
5 minutes.
Let's enjoy craniovertebral junction today. Okay, Harshad?
Yes, I love that topic of yours. I enjoy. I must have heard many times. It's now by heart for me. Just looking forward for it.
Thank you. Thank you.
Atul, you are doing wonderful.
Thank you. Thank you, Harshad.
You've given a great height to the Indian neurosurgery. I must say that.
Thank you. Thank you, Harshad.
Keep it up. Keep it up.
Atul, I got an email from your patient, originally Finnish, living in Canada, I
Yes,
think.
yes.
Yeah, she was extremely happy with the result.
Yes. He wrote to me. And she was very happy to see me on your show.
Yeah, that's good. Yeah. She will give very good advertisement for you.
Okay.
Certainly.
Bin has not joined. Bin.
Not yet. I don't see him.
I cannot log on. Why is this so hard? Oh, he's having trouble logging on. Okay, hold on. And- Oh, he's here. Okay. He got in. I don't know. Ben is here.
Ben,
Yes, he's here. With a minute to spare.
Hello.
Hello,
Hi, Ben.
hello, Subin.
Hi, John. Hi, Tuko.
hi Ben.
Hi, Professor.
I don't know
Good
what I don't know
Hi.
what's going on with Zoom. Ben, I don't know what's going on. They're
It's very
acting up,
hard.
temperamental. But you're here. That's great.
Mhm.
So, okay, ready to start? You are.
Yeah, when
Okay,
Subin
okay.
is here, and the Takashikon and Atul, of course, then we
Okay.
can, I think so.
Okay, let's go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. We have another UHA's China Neurosurgery Grand Rounds where he brings some of the best neurosurgery for mostly the Chinese and Japanese population and anyone else. Okay, okay, Yuha, it's all yours.
So hello, everybody. Welcome, Atul, again. I repeat introduction here. Professor Atul Goel is from Mumbai, India, chairman of King Edward's Hospital, and at the present times, he's one of the most important neurosurgeons in the world. How to become a good neurosurgeon? I never met a person who wanted to be a bad neurosurgeon. So how to become a good neurosurgeon? Train hard, 2 words only. Train hard, work hard, follow the way Professor Atul Goel is doing. Through the years, I have learned so much from him in many congresses, and now in the last webinars, I have learned also a lot. Neurosurgery has 3 parts: operative skills, research, clinical and basic, and then teaching. Atul is the king of the webinars, like John Bennett has found his name. He's doing very passionate and very convincing lectures. How to improve all the time? You should analyze your own experience. This makes you 5 times or even 10 times better surgeon. You should publish. There is a lot of talk about paper tigers, about those who are publishing a lot, they cannot operate. But this is not true. When you publish and analyze your own cases and think, then you will be by far better neurosurgeon than without publishing. You should not believe everything that is done in the classical neurosurgery. You should have new thoughts. You should think and observe your patients, your surgeries. This is very important. And you should learn from others. You should be humble to learn from others all of your life. So Atul has published huge number of papers, more than 800, as far as I can see, in PubMed. And 2014, he was elected as one of the most important neurosurgeons in the last 100 years. You see here Cushing, Dandy, Yasargil, Spetzler, and Atul Goel. So he's doing around 1,500 personal operations a year. How is this possible? You have to be excellent neurosurgeon to do that. You have to be a good organizer. You must have a good supporting team around you, and the patients and the society have to support you. And of course, for that kind of big number of cases, you need a big population. You should train your best young people. They should become better than you. This is life and this is biology. The younger generations are always getting better because they are standing on the shoulders of older generations and get ready all the experience that has been gathered through the years. So I give Atul Goel, Professor Atul Goel, the word. He's speaking about understanding craniovertebral junction. Please, Atul, go ahead.
Are you okay, Atul? Okay, we may have lost him. Hold on, he has a, Atul, are you there? Okay, there you go. We can't hear you, Atul, you have to unmute. Unmute, Atul, you have to unmute. Okay, there you go, there you go.
Okay, John, ready?
There you go, perfect, perfect.
Okay. So I'm extremely honored and extremely proud to be on the Juha's grand round and on his symposium. And I know I am talking on a very specific subject of craniovertebral junction. Craniovertebral junction surgery is unique, is an absolutely wonderful surgery. It is absolutely important surgery. It is absolutely difficult surgery. It is an absolutely philosophical surgery. Absolutely anatomical surgery. Absolutely technical surgery. It is complete neurosurgery. So this was my cover page of Journal of Neurosurgery that was published several years ago. And this is my technique. And I know Juha is not so much interested in craniovertebral junction. I know even Bin Zhu is not so much interested in craniovertebral junction. But let us see how I can make them interested in this field today. So craniovertebral junction surgery can be quite complex. You see, you get these kind of crooked necks, not only neck issue, cosmetic issue, but hands problem, hands weakness, legs weakness, spasticity in the limbs, difficulty in breathing, difficulty in talking, tingling paresthesia, numbness, spasticity, unable to walk, urine problems, stool problem. There can be hundreds of problems. The issue is if you treat them properly, if you treat them absolutely properly, you give them new life. On the other hand, if you do not treat them properly, you kill them. You completely devastate them. So we have to learn how to do, or we do not do. If we do not understand, we should not touch. So this was one patient I operated in another country. You see his neck was almost, you see, complete. Not only neck, he was sitting on a wheelchair and he was unable to move his hands and legs. I operated him and you see now he's not crooked, the neck tilt is little better, but he's enjoying with his family a completely normal life. So you can give new life to the patient and you can give new life to the wife and children, and absolutely new life. On the other hand, you do not treat, you kill them. You give such wonderful smiles in the immediate postoperative period. You see this divine smile. You see this king-like smile. You give them a straight neck. This is cosmetic, but what you give them is power in the hands. You give them power in their limbs, and you give them a new life. If you treat them properly, if you know how to treat them properly, you cannot try here. You know, the complications of surgery of craniovertebral junction are absolutely devastating. If you create a complication, you have complete devastation in the patient's life, in the relative's life, and both of them together will make your own life absolutely hazardous and complex and complicated. So this is the pillar, this is the human spine, and this is the pillar. This upper part of the pillar is, you see, it supports the roof. This V of this Y and this V is the craniovertebral junction. There are two very, very important joints here. One is occipito-axial joint, which is the most stable joint of the body, and atlanto-axial joint, which is the most mobile joint of the body. So mobility and stability are the hallmarks of craniovertebral junction. Whilst they are mobile and whilst they are stable, they protect the neural structures, which are the most critical neural structures in the vicinity. So this is a very important joint complex, craniovertebral junction. So now you see the beauty of this joint. This is atlas, this is axis. The transverse process of the atlas is the largest transverse process of the whole spine. The spinous process of C2, this is spinous process of C2, is the largest spinous process of the whole spine. If you see the atlas, the facet of atlas, there are multiple insertion points for ligaments on the upper surface of the atlas, where it connects with the occipital bone. You see, this is large and firm. If you touch the facet of atlas, it is the strongest bone of the body. There is no, apart from teeth, this is the strongest bone of the body. If you see this facet of C2, it is round and smooth, not like facet of C1, which is large and rough because there are many ligaments. Occipito-atlantal joint is the strongest joint of the body, and atlanto-axial joint is the most mobile joint of the body. So we describe this technique of lateral mass plate and screw fixation in 1994. And I actually did this operation, first operation in 1987. So now it is about 33 years ago, I described this technique. And those who are in craniovertebral junction know this technique, as this technique is not one of the premier technique in atlanto-axial fixation. The technique involves one screw in the facet of C1 and one screw in the facet of C2 and manipulation of the joint, which I will discuss. So the facet of atlas is the strongest facet of the whole body. The lower part of the facet of atlas is round and smooth. The upper part is rough and tough. The bones of the facet of atlas and axis are strong, and the screw, if you insert the screw in the facet, it has got a very tremendous strong hold. So my technique, which I described in the year 1987, and you will also know that many people in China are doing this technique. And I know of several young and senior Chinese neurosurgeons who are doing this technique. My technique since 1987, for 33 years, involves opening of the joint, open the joint, remove the articular cartilage, insert bone graft inside the joint cavity, and then do facetal instrumentation. So this is my technique. And I believe that you cannot compromise on any single of these three steps. You cannot compromise. You cannot do fixation without opening the joint. You cannot put bone graft without denuding the cartilage. You cannot do anything unless you put bone graft in the joint. So these three are very critical points in my operation. So one screw in C1, one screw in C2, open the joint and introduce bone graft in the joint. That is my technique. I was very familiar and very happy, and I was doing hundreds of transoral surgery long time ago. And in the year 1994, you can see this article, which was published in British Journal of Neurosurgery. I described odontoidectomy from the mouth, transoral, and then I introduced a plate from clivus to C2. So this technique was for the first time in the literature, metal was introduced from the mouth to fix the craniovertebral junction. Of course, now there are many other types of fixation methods, even those popularized in China. So this was the first case where metal was introduced. So you can see decompression and then fixation. This is another case which I did in 1995. I removed the odontoid process and then put a plate and then put one screw in the clivus, one screw in C2, and this was my fixation construct. This was another case which I did. You see, this was the case. I did very extensive decompression, and then I put a large iliac crest bone graft. So you can see. You can also note that I was very passionate about doing transoral surgery. And now today, not today, but for last 20 years, I have completely abandoned transoral surgery. And I have no hesitation to say that transoral surgery is completely an historical operation. The facets are the point of fulcrum of all movements. The movements occur at the facets. So the muscles are attached to the large spinous process of C2. They are attached to the large transverse process of C1. And these muscles move the joint, move the fulcrum. Fulcrum is at the facet, atlantoaxial facet. So the movements occur at the facet. So if you have to stabilize firmly, you have to stabilize the fulcrum of the joint movements. So the facets are the problem. All the muscles work on the facets. So the problem number one is the muscle weakness, muscle injury, muscle ill health or not good health of the muscles. And then the facets get disturbed because the muscles are not working properly and the weakness is manifested at the facets. So facets are the problem. Facets are the issue of all craniovertebral junction instability. And if you have to fix the facets. So in 1988, 33 years ago, this was my first case where I did one screw in C1, one screw in C2. This was radioulnar fixation plate which was cut. And you see several years ago, there is atlantoaxial fixation. There is no occipito-atlantal fixation. And subsequently, there are several hundred. Now my numbers of craniovertebral junction fixation with this technique is more than 3,000 cases. And I do sometimes 6 cases a day. And you can imagine the number of cases I'm doing of C1, C2 fixation with this technique. And there is no question, it is a difficult technique. It is a complex surgery. But if you can do it, there is no other technique as beautiful as this one. And you give new life. This is in a child. You see, this was a 1-year-old child, and there is syringomyelia here, and this was fixed, and this child is now several years old, and he's completely asymptomatic. Syringomyelia does not mean puncture of the syrinx. It is an indicator of an unstable spine. The treatment is stabilization. This is another 6 months old child. You see, unstable spine, complete arch of atlas is bifid and trifid and all these kind of unnatural spine, and then there is atlantoaxial fixation. You give completely new life even to small children. Screws, facet, and atlantoaxial instability. So these are the three keywords of my presentation. Another beautiful thing which I described in 1987 was the possibility of cutting the C2 ganglion. You cut the C2 ganglion and you expose the atlantoaxial joint. I am not doing C2 ganglion resection now, except in very, very rare situation. But my feeling is this surgery where you cut the C2 ganglion and open the joint or expose the joint was a revolution in the field of atlantoaxial fixation surgery. So I wrote this article, A Window to Atlantoaxial Joint C2 Ganglion Neurectomy. So we described this in 1987, that you can cut the C2 ganglion and expose the joint. It is not, if you are experienced enough to expose the joint, you can avoid sectioning in almost 100% of cases. Now I don't resect the ganglion. There is no question that if you want to do this surgery, you have to learn the vertebral artery anatomy in absolute perfection, and you have to know the facet of C1 and C2 in absolute beauty. You can appreciate that this vertebral artery can go right medially towards the odontoid process, close to the atlantoaxial joint. And also I mentioned for the first time that the vertebral artery has a dynamic relationship to the vertebral artery groove. You turn the neck, the vertebral artery goes here and comes out on the other side. So there is a dynamicity. And around the vertebral artery, there is a huge plexus of veins that can make your surgery very difficult and complex. So you have to learn the anatomy of this region in a very great manner. In 1988, I made this drawing on the bone, made 9 quadrants, and we said that you use the medial most quadrant to insert the C2 screw. C2 is the very important vertebra in question, and vertebral artery is in very close relationship to this pedicle where you want to put a screw. So medial and uppermost screws, uppermost quadrants are the best to insert the screw. So we wrote this article that you can introduce injury to the vertebral artery if your screw goes down. So your screw has to go up, your screw has to go up, and this is the best way of doing it. But of course, in some selected cases, even this is an acceptable direction of screw insertion. So atlantoaxial dislocation, mobile, you have to put the screw medially and you do a fixation and you see the ossification of atlantoaxial joint. Radiologically, all right, but you have given absolutely new life to the person. So mobile atlantoaxial dislocation, fixation, you see the bone fusion, the screw in C1 and C2 facets. This is another mobile dislocation. You see mobile, and this is after surgery. And this is the impact on the spinal cord. You do fixation, all impacts are finished, and there is a huge impact on the patient's life. You see, this is mobile reducible atlantoaxial dislocation. Open the joint, remove the cartilage, introduce bone graft, and then do fixation, and wonderful clinical outcome. These are odontoid fractures. You know, there is a technique of transoral odontoid screw insertion. I completely do not like that technique, and I think it is quite a, maybe easier technique, but easy will not work in craniovertebral junction. Once the joint is destroyed and disrupted, you have to do a solid C1, C2 fixation. This is another case of odontoid fracture, and you have done fixation. I have got several hundred cases of odontoid fractures which have been completely cured by lateral mass fixation. This is another case of os odontoidium, which looks like fracture odontoid. And this is also, if you read the literature, many people do not understand os odontoideum. And even if you see the Western literature today, many people come and do transoral surgery and then do occipitocervical fixation. Absolutely not necessary. Os odontoideum indicates mobile, unstable atlantoaxial joint, and you have to do atlantoaxial stabilization. So my surgery is in this position. You see, I give traction this way and head high. So the venous congestion here is reduced and there is no pressure on the eyeball. This is a floating head position. I will just show you. You see, this is how my screw of C2 will go like this. In this direction, the C2 screw will go. And now I want to show you one case before I go further into this. And when admitted, he was. What I will do is, I will stop the voice here. So I'm going to show you. So this is atlantoaxial dislocation, as you can see. It is a very small reduction on extension of the neck. And these are the facets. Now this is not a new case which I'm showing you. In this, I'm going to show you the technique of, so it is very important. I put a traction on the patient's head and then move the patient under, I hold, this is my hand. And when I turn the patient, there is somebody holding the neck here very strongly. And then the patient is turned. And very important to give a very good position. You see, my hand is not moving the traction till it is completely fixed. So I then put this wire and then I remove the traction. So it is almost not touching. You see this one, the head, the face and the eye is not touching the head holder. This is very old thing here. And then I prepare. Now this is the craniovertebral junction. This is almost live without much editing. My incision will not be so big now. So I'm exposing the craniovertebral junction. And first thing, I will see the C2 spinous process. You see, this is C2 spinous process. I will do subperiosteal dissection. And if you notice in my operation, there will be no or very little coagulation. So that is my technique. Of course, everybody has the right to have his own little fancies in neurosurgery and in surgery. So I am doing sharp section on the C2, and then I will expose the C2 C1 joint. Now you can realize that this is unfortunately, this is not a new case. Then you will see I can already see some issues here. Now you see here, I am going to the joint and my assistant is constantly, here in this area, there can be quite a bit of blood loss, as you know. And you can have, you see here, now it is little bit magnified image. You see here, this is C2 ganglion. You see here C2 ganglion? Carefully see, this is C2 spinous process, lamina, this is pedicle going into the facet. I am exposing subperiosteally and I am putting this is C2 ganglion. I am not sure if you can see it properly. Now I am exposing the joint, and this presentation, this operation is not very heavily edited. I can, as I mentioned to you, I sometimes do 5 or 6 cases a day with this kind of fixation. Here I'm cutting the C2 ganglion. I don't cut the C2 ganglion nowadays, but I selected this video because I am showing you the technique of sectioning of C2 ganglion. and then I will show you how I expose the joint. You see now, just carefully see. This is the C1 facet. I know it may not be clear, but those who are doing this technique, those who are in this business of C1, C2 will definitely understand what I am doing. See, I have opened the joint with this small osteotome, and I am opening, you see here, how I have distracted the facets, and the whole joint is open. This is the C1 facet which I am cutting to expose the posterior surface of C2 facet. Sometimes, you know, it can be quite a difficult operation because of the venous bleeding. The thing is, you have to handle the venous bleeding quickly and effectively. And once you have, you know, you can use the services of Surgicel and services of gel foam and all those things. But even these things are not so much required, I must tell you, because, you know, these are sometimes quite tricky operations. But you have to learn, all young and old neurosurgeons have to learn this operation. In the modern neurosurgery, you cannot say, I don't want to learn craniovertebral junction stabilization. And I will show you today that how important it is to learn. Now you see, I am introducing bone graft in the articular cavity. Did you see that? This is from iliac crest. How much bone I am introducing in the articular cavity. Now, in the modern neurosurgical perspective, you just cannot say, I don't want to learn C1, C2 fixation. Because orthopedic people will say craniovertebral junction is neurosurgical issue. They will say lumbar spine is mine. Neurosurgeon wants to say lumbar spine is mine. Orthopedic surgeon wants to say lumbar spine is mine. Craniovertebral junction is yours. Neurosurgeon says yours. Orthopedic surgeon says yours. But it should be ours. It should be our domain. And it is a wonderful, there in neurosurgery, there is no other surgery as result oriented as atlantoaxial fixation. Because if you are able to do fixation, you see what I am doing is I am drilling the pars. And you will see why I am drilling the pars. Here the pars, the lateral aspect of lamina, I have drilled. Now you see why I have drilled, I will show you. So in my joint, there is a lot of bone graft. I am making a hole in the facet of C1. And you can introduce straight into the facet. And there is nothing that can be at any danger if you put this screw. So I am putting this plate and screw at this point of time. You can use screws and rods. Like you can use polyaxial screws and rods. I used it, but there is no way. This is the best way to fix the atlantoaxial joint. And you will see why. Why I'm saying you will see. So what I'm doing is you remember I had drilled the pars to put the plate in the right position. If you don't drill, the plate will not turn here. So now I am making a hole. You see, after seeing the pedicle, you see, I see the pedicle and then make a hole. You can use neuronavigation for this, but I used to use neuronavigation, but I don't think I need neuronavigation now because it is not required. Now I am putting a screw in the pedicle of C2. You see how medial I am going and how superior my screw is directed. Of course, this smoke should not come. And my screw has gone there in the C2. And now my plate will come here. and then there will be C2 screw fixation. And once you tighten these two screws, immediately the motor evoked potentials will improve 30 or 40% MEPs. 40% as soon as the screws are tightened. Post-operatively, of course, the patient will improve after a reversal from anesthesia. And then you have to tighten the screws. You can use, of course, polyaxial screws and rods, but that is, these screws are a little bit thinner. They are 26 millimeter long and 2.6 and 2.8 millimeter and sometimes 3 millimeter in diameter. So you are tightening on the bone, this plate. And this is a very, very strong fixation. There is bone in the joint cavity and the whole thing is then becomes stabilized and firmly fixed. And you can tighten it very strongly. Then there is no possibility of any movement of the atlantoaxial joint. Then you can control the bleeding. And you must realize this operation is not very much edited. It may be a little bit edited, but not too much. I sometimes finish this operation in 45 minutes from skin to skin. Now I will show you the other side. I don't remember this tape, but you just see what I am doing. So you see I am going, this is the C2 spinous process. This is the lamina, and I am doing subperiosteal dissection to expose the C1, C2 articulation. Little bit I am drilling the parts to make way for the plate when it will come here. You see, I'm opening the joint here. You can actually, keep the other side loose. I am then introducing bone graft in the joint cavity. You have to do it. If you don't want to do it, then don't do it. But don't touch the atlantoaxial joint in that case. If you have to learn to do, you have to do complete operation. You cannot do half-hearted operation. I described this operation when I was 27-year-old or 26-year-old. There is no way you can say, I don't want to do and I cannot do. You have to do means you have to do. And if you have to do, you have to do properly. There are no compromises here. You say, okay, I will do occipital fixation. What occipital fixation? Occipital fixation is an absolutely negative operation. Never touch the occipital bone. Occipito-atlantal instability is an absolutely rare situation. So this is my screw going in the C2 pedicle, superior and medial, under direct vision. No compromises in this operation. Remember, no compromises. Once you are able to do this fixation, the result will be in your front of your eyes in the evening of operation. And you will find a person with new life. His breathing will improve, his voice will improve, his hands will improve, and he will have a new vision and a new destination. So then I tighten the screws after putting and they can be very tightly tightened. You see earlier, before we described this technique, midline procedures were very popular, like midline wiring, midline. Those procedures are completely non-acceptable procedures. If you cannot do this, then you do that, but you must learn to do. So now what I do is I cut all the muscles. Very important to cut all the muscles which are attached to C2 spinous process and to C1 arch. Arch of atlas, not many muscles are attached. But C2, this sectioning of the muscles is very critical because these muscles can break any implant. That is why I don't like transoral fixation, because by transoral you are not able to drill these muscles. As long as these muscles will be present, there will be movements. And when these muscles will act, they can break any kind of metal that is put from the front or from the mouth. And very elaborately you drill the bones of this C2 and lamina. And the arch of atlas. You see arch of atlas, you drill. And then you put lot of bone graft in the midline. You see lot of bone graft in the midline. And then you do the closure. So my friends, this is the technique. Difficult, all right, but absolutely magical, magical. Okay, so now I will go. So you can use navigation. We have navigation in our department, and I used to do, you can avoid this vertebral artery high riding and get the screw in action. But now I don't use these kind of navigation. I don't use intraoperative C-arm or radiographs, and I don't need all those things. So the muscles attached to the C2 spinous process are very large and huge. C2 spinous process is the biggest spinous process of the whole body. You have to cut the muscles of the C2 spinous process if you want to avoid movement of the region and stabilize and fuse the atlantoaxial articulation. Another technique that I described, one screw in C1 and one screw like Megal's technique, transarticular. You see, this is double insurance. Sometimes you have an issue, you can use this, but this is not necessary. The pedicle of C2 and facets are so strong that you do not need to go like this. This is one more case. You see, this is after surgery, and this screw is in C1 and this screw is in transarticular fashion. So the vertebral artery, high riding vertebral artery can be a big issue when you put the C2 screw. And this vertebral artery has to be very nicely understood if you have to operate. And nowadays I do these kind of 3D models. You see 3D models? And this is abnormal course of the vertebral artery behind the C1 facet, and you can have very big disaster. This is another case where the vertebral artery is going behind the facet of C2, and you can have a big problem at hand. So you make these models and they are wonderful. This is another case where there is C2 and the vertebral artery is going behind the facet of C1. But if you have this model, you can understand the anatomy very nicely, and then you can do fixation. You see, this is a very high vertebral artery foramen, high vertebral artery, and we have mobilized the vertebral artery and introduced the screw. This is pre-op and this is post-operative. So vertebral artery, you see how intensely this vertebral artery can be seen with these 3D models. So you know exactly where to put your screws in C1. You see this vertebral artery also has an abnormal course over the C1 facet. So whether there is assimilation of atlas or not, you don't say when there is assimilation, I will do occipital fixation. That is completely not necessary. When there is assimilation of atlas, the facet of atlas is quite huge and big, and you can do a beautiful C1, C2 fixation. So these 3D models are an emerging investigational revolution in craniovertebral junction surgery. This is the magical bone and the majestic bone of axis. This is atypical vertebra. You see there is a odontoid process, which is atypical. And the other atypical thing is this is the superior facet of C2, and this is the inferior facet of C2. When you put the screw, you put the pedicle and go to the superior facet. That is very important for you to understand, that you are going and you are putting the screw through the pedicle into the superior facet, not inferior facet. But if you cannot put, because the vertebral artery is high, you can use the inferior facet. Now we describe this technique. You see one screw in C1 and one screw in the inferior facet of C2. You see, this is the superior facet and this is the inferior facet. Now here, if there is a high riding vertebral artery, like in this case, you can use the inferior facet to put your screw. That is very important new technique that we described. You see, this is high vertebral artery, very high riding vertebral artery. And one screw I put in the C1 and one screw I put in the inferior facet of C2, inferior. So you have a very beautiful construct. This is another case. You see there is marked huge problem in the facet of C2 and high riding vertebral artery. So I introduce my screw in the inferior facet of C2-3, inferior facet. And you see this is preoperative and postoperatively the complete reduction and realignment of craniovertebral junction. This is another case of very complex. You see huge, the basilar invagination, fixed atlantoaxial dislocation. I open the joint, introduce bone graft in the joint, and because there was high riding vertebral artery, I introduce inferior facetal screw on one side. This is another case. You see there is a very high riding vertebral artery here, very complex situation. And this vertebral artery is very also in an abnormal course. So I mobilize the vertebral artery here and introduce the screw in C1 and introduce the screw in C2 inferior facet. And you can see the beautiful clinical outcome. So mobilization of the vertebral artery. So we published this technique of opening drilling the posterior aspect of the high riding vertebral artery and mobilizing the vertebral artery and then introducing the screw here. So this is another technique that we recently published. You see this is a high riding vertebral artery. So we mobilized the vertebral artery, pushed it down, you see pushed it down, and then introduced the screw in the C2 facet and in the C1 facet, and then stabilized. So this is a beautiful technique, and I want to show you this technique. Mobilization of high riding vertebral artery. Now you see here, this is the os odontoideum. And you see high riding vertebral artery and very high riding vertebral artery. So you drill here and mobilize more on this side, on the right side, not so much on the left side. So this is my surgical position. This is again, you see this is C2 spinous process. Now here on the left side, I am not doing mobilization. Left side mobilization is not there. I'm just showing you the technique once again for you to understand it once again a little bit better. You see, I have opened the joint. And I have introduced this osteotome and I'm distracting the facets. And I am exposing the C1 facet. You see C1 facet. This is C1 facet. Then I am doing this drilling to expose to drill the pars to get my plate in proper position. You see, you are seeing some extradural venous bleeding, and that venous bleeding is more in cases of syringomyelia. Now you see the joint, this is C1, this is C2, and I'm making a hole in the C1 facet. You see how much I have distracted the facet. Then I'm introducing bone graft in the joint. Then I'm doing C1 screw fixation over the plate, as you are seeing. Then I am turning the plate. You see the vertebral arteries here, but it is not so much high riding on this side. So I have positioned the plate in that area. After carefully seeing under vision the pedicle, I am introducing the screw. I am doing under vision after seeing the vertebral artery hole properly. You see, then I tighten the C1, C2 screws. You can tighten both the sides at the same time. There is no need to tighten this first. Because if you tighten, then there is a problem in mobilization of the other side. But here I am tightening. Now I am going to the other side. Now you see here the vertebral artery is very high. Now you please carefully see, it may not be such a good editing and all those tape may not be so good, but those who are in this business of craniovertebral junction will know what I am doing. You see, this is the vertebral artery area. Just carefully look at this here. Just underneath here is the vertebral artery groove. So what I'm doing is, just see here. First, I'm doing my C1 screw fixation. This is C1 facet. Now you must remember my experience, personal experience with this technique is more than 3,000, maybe much more than that also, more than 3,000. Today morning, I did 2 cases of C1, C2 fixation. Apart from my other cases of skull base and acoustics and all those things which I love, this is like a very important part of my operative business. Then I'm putting bone graft in the joint. And if you realize this tape is also not very significantly edited. So I have introduced the bone graft in the C1, C2 articulation. And then I am putting this plate, this screw in the C1 facet. And you may also have some difficulty if I say that many of these cases, I do not use a single coagulation throughout the operation. Not a single coagulation in many of these cases. Of course, in some cases, I do use coagulation. There is no question. If it is spurting, I am not a fool not to do coagulation. Now I am trying to expose this vertebral artery. You see, it is a very thin bone, and underneath the bone, there is vertebral artery. So I cannot put screw like that because that may damage the vertebral artery. So what I am first trying to do is, I'm trying to expose the vertebral artery in the vertebral artery groove. I must say that this is maybe a little bit complex surgical procedure, but I can also tell you that in many situations of complex craniovertebral junction, you have to do this. You see now my vertebral artery, I have mobilized with my dissector downwards. My dissector is pushing the vertebral artery down. Then you see the vertebral artery is under the hole of my plate. Now what I will do is, I know I have to mobilize the vertebral artery. So I have used the dissector to push the vertebral artery down. I can also tell you that those who are in this business of vascular surgery and those who know how to handle and mobilize and take care of the blood vessels, this operation can be difficult, but I will not say this is impossible, because there is a lot of bleeding in the venous circulation here, and there is a possibility of damaging the vertebral artery. So you have to be absolutely sure. If you are not sure, you cannot do it. You see, now I have pushed the vertebral artery down. If you realize that, then I am bringing my plate here on the vertebral artery. Then I am pushing the vertebral artery down under vision. And then I have introduced the screw over the vertebral artery. In some rare situation, this can be a life-saving operation. And if you can do it, you can do a beautiful operation. There is no question about it. As I have mentioned to you, there are various permutation and combinations that you have to use, and you have to use them elaborately through the operation. And once you have tightened the screw, then you have to drill that area of C1 and C2, introduce a lot of bone graft, and then you close. And then I will show you, you see this vertebral artery has been mobilized and my screw has gone into the C2 facet. You see how it is over this is the vertebral artery groove, and your screw is going like that. This is another case. No, this is the same case where the vertebral artery, the screw is going like that. Several years ago, I also described C2 spinous process and C2 laminar screws. You see, sometimes you give credit to some other publication, but you see this publication, 2004, 17 years ago, I described C2 laminar screws and C2 spinous process screws. So this was my article in 2004, and this is the publication. And you see this occipitocervical screw, the C2 screw is going into the C2 spinous process. As I mentioned to you, I do not use occipital bone now at all. And I do not use spinous screws or spinolaminar screws or laminar screws at all. No question about that. I also described this technique, many in China know it, joint jamming technique. You open the joint, introduce these kind of spacers, and I call this technique a joint jamming technique. This is also a very popular way of stabilizing the C1, C2 joint, and also distraction of the facet in cases of basilar invagination. I call these spacers as goel facet spacers. I do not use these spacers very often. So I wrote this article, Atlantoaxial Facet Distraction Spacers, the Indications and Techniques, several years ago. So you see here, this is the unstable spine. I introduced spacers in the joint. And as I mentioned to you, I do not use these spacers too often these days. So this was another case where I have introduced these kind of spacers in the atlantoaxial joint. This is the complex craniovertebral junction, and I have done this fixation on one side because the vertebral artery was very high, and for some reason I could not mobilize the vertebral artery, so I introduced the spacer on one side. So spacer, you have to know, and you have to very carefully understand these spacers. Sometimes, you see, I describe this technique of transcranial insertion of Atlas C1 screws. Now you see here, this is, I do not use occipital bone as I mentioned. So now the C1 is in a very difficult situation. C1. So what I do is do a small craniectomy here and go extradural and put the C1 screw. You see here, C1 screw, after doing a small little craniectomy, I introduce C1 and then do C2 screw. So this is a transcranial insertion of C1 facetal screws. This is another case where this is the C1 facet, and you see this is the occipital scoma. This was very high. I could not reach. So I drilled this little bit occipital bone, and then extradurally I went into the C1 facet. So transcranial insertion is possible in some kind of difficult cases. So this is another case where I did little bit of craniectomy, you can see here, and then introduce the C1 screw in a transcranial fashion, introduce C2 inferior facetal screws, and then I mobilize the vertebral artery on the other side and introduce these two transarticular C2 screws. So this was a very beautiful fixation in this person. Talking about occipital bone, you see the wires fixation in the occipital bone and C2 fixation is a very well-known technique. And this was in 1987. 1987, we described for the first time in the literature occipital screws. You see, occipital fixation using screws was first described by us in 1987, 34 years ago. And I have to now say very clearly that inclusion of occipital bone in the fixation construct is not necessary. In extremely rare situation where you are not able to do C1 fixation, you can do occipital fixation, but occipital inclusion of the occipital bone in the fixation construct is a suboptimal kind of fixation. Now you see this case. In extension, there is no dislocation, inflection, the whole of the odontoid process is going in. So we label this as vertical, mobile, and reducible atlantoaxial dislocation. So most of the cases of basilar invagination are vertical, mobile, and reducible atlantoaxial dislocation. So those who are in the field of craniovertebral junction know it very well, that there was an entity called fixed atlantoaxial dislocation, and decompression was the treatment, transoral decompression, foramen magnum decompression. So there was an entity called fixed atlantoaxial dislocation. In the year 2000, means 21 years ago, we described that there is nothing called fixed atlantoaxial dislocation. You open the joint, distract the facet, and reduce the dislocation. And then fixed. So there is nothing called fixed. Now, of course, many of you know that the fixed atlantoaxial dislocation entity does not exist, but 20 years ago, this was the situation. So the inflection, extension, there is no movement. Both extension, you see in extension, this head, it is still very heavily fixed. So I opened the joint, distracted the facet, and reduced the dislocation. Otherwise, I was myself doing transoral decompression and then doing fixation. So there is no need for transoral decompression. This is another case of fixed dislocation. Open the joint, distract the facet, reduce the dislocation. So there is absolutely no need to remove the bone of the occipital bone, and no need to do transoral decompression, no need to include the occipital bone in the fixation construct. open the joint, distract the facet, and reduce the dislocation. I have got several hundred cases where I have done this fixed atlantoaxial dislocation, reduction and fixation and realignment. Many a times I use these spacers, but many a times I do not use these spacers. You see this odontoid process is touching the C1 arch. There is no need to do decompression, no need to remove odontoid process. Open the joint, distract the facet, and do craniovertebral junction realignment. So we published this paper in the year 2004, and this technique has completely revolutionized craniovertebral junction surgery. There is no question in my mind that introduction of this technique has completely revolutionized craniovertebral junction surgery. When there is fracture of the arch of atlas, there is lateral dislocation of the facets. What you do in this is a very complex situation. We introduce the concept of manual realignment. Open the joint and manually realign the facet and reduce the dislocation. So this technique has completely changed the treatment. Otherwise, there was only one treatment for this problem, and that treatment was decompression. So there is no question of decompression. Rotatory dislocation. You will get a child with this kind of rotatory dislocation. There is no pain, there is no neurological deficit, and suddenly somebody taps on the head and there is a dislocation. This is rotatory dislocation. Rotatory dislocation. Open the joint, manually manipulate the facet, realign the facet and do fixation, and you can give a wonderful smile to these patients. And you can give a normal neck. You see the normal and long neck in these patients you can give. So we introduced this technique of facetal manipulation and fixation for rotatory dislocation. You see there is a rotatory dislocation, and this is the patient, and this is the beautiful reduction. This is the neck, rotatory dislocation and basilar invagination, of course, in this patient, and the vertebral artery is going in a very dramatic fashion. Open the joint, learn the art of opening the joint, learn the art of operating in bleeding territory, learn the art of handling the blood vessels, learn the art of screws and plates and orthopedic technique, and use it for us. And you can make this neck beautiful and straight in the immediate post-operative. This is on the first night of surgery. This is another patient. You see the hair is gone, but the neck is straight, and you see this rotatory dislocation and this fixation, and this is in the immediate, after about 10 days of surgery. This was my earlier case. I used to do distraction and reduction. You see there is a facet is depressed on one side, so I introduce a spacer on one side. I do not touch on the other side. I do not do this technique now. You see the odontoid process is here, and I introduce the facet distraction, and the odontoid process is now in the midline. And sometimes both the facets can go down, and the person is holding the chin to hold the facets. So I open the joint, bring the facets back into shape, and then do fixation, and you give instantly a new life to this person. Basilar invagination was not, nobody knew how to treat basilar invagination. In 1964, this was an article, and if you read this article very carefully, here it is mentioned that craniovertebral junction and basilar invagination are only for people to see and forget. They are anatomical curiosities and radiological curiosities. Surgery was not at all and decompression then came into picture. In the year 1998, I introduced this paper, which is very highly cited now. I introduced basilar invagination with my experience with 190 cases in 1998. I divided basilar invagination into two groups, One group was when the odontoid goes up, and the other group was when the tonsil comes down. So in 1998, the concept was that these are fixed anomalies and decompression is the treatment. That was the concept. So for this group, we described transoral surgery, and for this group, we described foramen magnum decompression. Fixation was question mark at that time, because my own concept was that this is a fixed problem and decompression is the treatment. So for group 1, we described transoral surgery. And for group 2, we described foramen magnum decompression. So I myself described foramen magnum decompression. And for the first time in the literature, we said that for Chiari malformation, dural opening is not necessary. This was the first article in the literature which said that don't open the dura for Chiari and syrinx. And this was the first article in the literature that mentioned that the foramen, the posterior cranial fossa volume is reduced in Chiari malformation. Then in 2004, I introduced an absolute revolution in the field where I introduced the term craniovertebral junction realignment. So this was basilar invagination. For in 2004, my concept was when Chiari malformation is there, you do foramen magnum decompression. But for group A, you do craniovertebral junction realignment. I have started doing this technique since 2000. So now 21 years ago, and I have now got hundreds of patients where I have done open the joint, distract the facets, and do craniovertebral junction realignment, basilar invagination, realignment, no decompression. So you see how the whole concept has changed. So this is basilar invagination, craniovertebral junction realignment. This is huge basilar invagination, and the whole thing has been reduced. There is no decompression either from front or from behind. No decompression. Otherwise, I was, as I mentioned, I was myself doing transoral decompression. This is another case. You see the whole thing has gone in and it has come down. Basically, what I'm saying is basilar invagination is an unstable atlantoaxial joint. You do atlantoaxial stabilization. You see, this is unstable. So we introduced the term that this is unstable. And this is not fixed, and this does not need decompression, and it needs stabilization, and if possible, realignment. You see this preoperative, and you see postoperative. There is no bone removal, only atlantoaxial fixation. So you have to learn this technique. You cannot say, oh, no, I don't want to learn. No, don't learn that. But you will miss out this wonderful material. You see, this is unstable, and you do craniovertebral junction realignment. The whole odontoid process has gone in, and you see the whole odontoid process has come down. You know, when I introduced this technique in 2000, and I was giving several lectures, people certainly ridiculed me. They laughed at me, and they gave very nasty comments on my presentation at that time. But now you know the whole world is doing this. That is basilar invagination. And if you see these facets, and if you see this fixation, the odontoid process has come down, completely realigned. This is basilar invagination, C2-3 fusion, clipal file abnormality. You see complete realignment. See the facet of C1, see the facet of C2. You see the facets of C1 and C2. This is another case of basilar invagination. You see the facet of C2, and you see post-op. You compare this one and this one. Complete realignment. What I'm showing you is the image. What I'm not showing you is the patient who has got an absolutely new life. You see, this is touching the foramen of magnum behind, the posterior rim of foramen of magnum. Don't do decompression here, which is a negative operation. You see, the whole odontoid process has been brought down, and craniovertebral junction realignment has been done. This is preoperative. The whole odontoid process has gone inside the skull bone. The facets are in abnormal situation. You see the whole odontoid process has been brought back into situation, and there is atlantoaxial fixation. This is another case where this is the complex realignment has been done and beautiful. I was doing, and I have done several hundred transoral decompression for such cases. This is another case. You see the odontoid process is going and touching here. And what I have done is complete realignment of the craniovertebral junction and atlantoaxial fixation. If you see the Western literature, if you go to any Western country, they are still doing transoral decompression and occipitocervical fixation for this. And when I say it is not required, I am several times ridiculed, particularly in the Western countries. And I know in China, I am a hero because many people in China are doing what I'm saying, and they are absolutely happy with what they are doing. You see, this is complete basilar invagination, and you see such a beautiful craniovertebral junction realignment. This is another case, preoperative and postoperative, and you see the unstable craniovertebral junction. This is another case. You see the whole thing is going back, and the whole thing has been realigned craniovertebral junction. So this was my first case in the year 2000. You see this child in a very miserable state, and the occipital bone has completely gone to the petrous bone. This was the basilar invagination. I did my first case in the year 1999. And I did this realignment. You see craniovertebral junction realignment. And this patient, just father is little bit supporting the child, but you see atlantoaxial bone fusion and completely cured. So I'm just showing you some preoperative and postoperative cases just to make you convinced that there is no question of doing transoral surgery, no question of doing foramen magnum decompression surgery, no question to argue with me and ridicule me. There's no question. You cannot do that. Now, of course, I have suffered during that time in a very nasty fashion, which many young people will not even realize how much I had to suffer when I introduced this technique. You see, this is pre-op and this is post-op in a beautiful realignment. This is pre-op and post-op in beautiful realignment. And as I have mentioned to you, I have got several hundred cases with this kind of realignment of craniovertebral junction. See preoperative and postoperative. You see where the odontoid process and how the whole region is realigned. So in craniovertebral junction basilar invagination, there was an era of nothing. Then there was an era of decompression. Then I myself said that you do decompression and fixation. And now firmly there is era of craniovertebral junction realignment and only fixation, and there is no era of arguments anymore. And I have no hesitation to say that I have completely demolished transoral surgery into history, and there is no question of doing transoral surgery at all. Now I want to take you to another chapter of craniovertebral junction. And I am saying that chronic atlantoaxial dislocation, there can be acute dislocation and there is chronic dislocation. Basilar invagination is a manifestation, is a musculoskeletal manifestation of chronic dislocation. So there is nature plays a very huge role. So basilar invagination is a part of natural protection. Now I will show you. You see this short neck, torticollis, a natural protection of long-standing musculoskeletal changes in basilar invagination or atlantoaxial instability. You do atlantoaxial stabilization, the neck becomes long and the neck becomes straight. The neck becomes long and the neck becomes straight. So torticollis, short neck, platybasia, clipal file abnormality, bone fusions are all secondary to one problem, and that problem is atlantoaxial instability. You stabilize the atlantoaxial joint, you give a new straight neck to the person. So this is still crying but crying with a straight neck, what you have done is you have not done anything else, but you have done atlantoaxial fixation, and the neck is straight and neck is absolutely brilliant. More than the neck, the entire person becomes new, hands become strong, legs become strong. You see this neck, and this neck is after about 3 months of surgery, the neck has become straight. This is another patient who has come like this. Basilar invagination is a manifestation of chronic atlantoaxial dislocation. Chronic is a musculoskeletal malformation. And these CSF spaces that you are seeing, this is external syringomyelia, external syringobulbia. These CSF spaces, I have called them external syringomyelia and external syringobulbia. There is no need to do transoral decompression. You see, you completely do fixation and you give new smile to this patient, long and straight neck. This is another patient who was smiling even before operation, and he has stopped smiling, but you can appreciate the long neck and straight neck. What I have done is just atlantoaxial fixation. So atlantoaxial fixation, chronic atlantoaxial fixation can lead to musculoskeletal abnormalities of short neck and torticollis. This is another case of basilar invagination, twisted, see the long and straight neck. This is another child with basilar invagination, atlantoaxial dislocation. I can introduce a straight neck, and I have introduced a beautiful smile on this. This patient has completely deformed neck. And he is not only having a deformed neck, he's having his limbs, he's not able to walk, he's on a wheelchair. If you understand this problem, if you know that atlantoaxial instability is the cause of the entire musculoskeletal changes, you see there is a bifid arch of atlas, which I am saying is also a protective phenomena. Short neck, torticollis, these muscles under spasm. You see these muscles under spasm are manifestations of atlantoaxial instability. You do atlantoaxial stabilization, you give him a new life with his family, an absolutely new life. Cervical fusions, clipal file abnormality, assimilation of atlas, C2-3 fusion, pan-vertebral fusions are all manifestations or natural protection done by God to protect the person from atlantoaxial instability. You see, there is a multi-level bone fusion. There is no compression at the craniovertebral junction. But if you know that the craniovertebral junction is unstable and you do atlantoaxial stabilization, you give a new life to this person. If you do any kind of unnecessary bone work in a fused spine, there is only one thing that can happen, and that is harming the interest of the child. You do atlantoaxial fixation, you give new life. We introduced the concept, this was published in Neurosurgery, that bifid anterior and posterior arches of atlas are manifestations, are protective phenomena. You do flexion, the bifid opens. You do extension, the bifid closes. So it is a dynamic process, and this is a protective natural phenomena. You see, this is bifid, and those who will operate on these cases will know how mobile the facet of atlas is. You fix the screw and the complete facetal stabilization occurs in front of your eyes, and motor evoked potentials can 60% or 70% improve as soon as you tighten the screws. So bifid arch of atlas is a natural protective manifestation of an unstable atlantoaxial joint. So when you see bifid, even if you see nothing else, it is an unstable craniovertebral junction, you do atlantoaxial stabilization. When you see bone fusions, when you see bifid, even if you do not see atlantoaxial instability, you have to do atlantoaxial stabilization, and you give instantly absolutely new destination to these patients. Os odontoideum, I published in World Neurosurgery my experience with 190 cases. If you read this article, properly. Those who are interested in this field of craniovertebral junction, please read this article. In this article, I mentioned that all my 190 patients improved after surgery. There was not a single complication in this operation. So os odontoideum, do C1, C2 fixation. As I mentioned to you, even today in the West, transoral surgery is done for this problem, followed by occipitocervical fixation, which is absolutely an suboptimal kind of operation. So this is os odontoideum, and you see the unstable craniovertebral junction. You do atlantoaxial fixation. There is os odontoideum here, and you do atlantoaxial fixation. This retroodontoid cyst does not need to be disturbed. These are natural protective. So os odontoideum is a protective mechanism. These are musculoskeletal problems. Now I want to show you what happens to how the neural system protects. So syringomyelia, I am saying, is not a pathology. It is a neural transformation in cases of chronic atlantoaxial instability. You carefully listen to my words which I am saying. So there is a tumor and syringomyelia. So syringomyelia is secondary. There is kyphosis and syringomyelia. Syringomyelia is secondary. Tumor and syringomyelia. Tumor is the problem. Syringomyelia is nature's introduction. So the concept is treat the primary etiology. Syrinx manipulation should not be done. And I have no hesitation to say that I am talking about this for last 20 years. And we have completely revolutionized the treatment of syringomyelia. Syringomyelia was treated with syringosubarachnoid shunts, with various kinds of shunts. Now, very few people in the world are doing syringomyelia shunts. We said that this is dural cover. So dura can cover the child. It is like mother. It can hold the child, it can grasp the child, but can never squeeze the child. Dura can never be a problem. So in Chiari malformation, we said that there is no need to open the dura. I said this in the year 2000. Arachnoidal sectioning and tonsillar resection, I said in the year 2000 that these procedures are not necessary. I said in the year 1995 that syringomyelia is helpful and not harmful. You remove the tumor, not the tonsil. Tonsillar herniation is secondary to the tumor. You find out why there is Chiari and remove why the cause. So you see there is atlantoaxial dislocation, there is syringomyelia. You treat the atlantoaxial instability, not the syrinx. And those who have seen this, they know the implication of not touching the syrinx. As we matured further in the field of craniovertebral junction, we introduced a new concept called central or axial atlantoaxial instability. This central instability is present in chronic situation, chronic atlantoaxial instability. There are musculoskeletal changes in chronic situations like basilar invagination. There are neural changes like Chiari malformation and syringomyelia. And there can be myelopathy related to cervical degenerations, chronic spinal deformities, ossified posterior longitudinal ligament, and Hirayama disease. So I have no hesitation to say, 10 years ago, I described this entity of central instability, complete revolution in craniovertebral junction surgery. This is neck and this is back. This is back and this is neck. This is craniovertebral junction instability. This is back instability. Neck and back are similar. Like lumbosacral listhesis, craniovertebral junction instability is the problem in basilar invagination. Like you treat lumbosacral listhesis, you treat basilar invagination. That is the concept. So this is central or axial instability, which has introduced a new vision in craniovertebral junction. So let me talk about this. So this was in long time ago, maybe 20 years ago, we said that listhesis C1 over C2 listhesis is the cause of basilar invagination, is the cause of syringomalia and Chiari. Listhesis is the problem. You treat the listhesis and there can be craniovertebral junction realignment. So treatment of listhesis was the issue we talked about 20 years ago. This is another case of listhesis as a cause of basilar invagination. You see this listhesis, C1 over C2 listhesis. You treat the listhesis and you realign the craniovertebral junction. This was the earlier concept. There is no need to do foramen magnum decompression. There is no need to do odontoid resection. This is another case of listhesis. You see there is Chiari malformation and basilar invagination. I have treated the listhesis, and there is no need for any kind of bone work in this case. So then I introduce a new concept. You carefully see to this slide. So we first talk of listhesis of C1 over C2 listhesis and the atlantodental interval disturbance, compression of the neural tube. You treat listhesis and there is no need to do any kind of decompression. But this kind of basilar invagination, the whole world is still doing foramen magnum decompression for this problem. But you see here the beauty, there is the facet of C1 is behind the facet of C2. I call it type 2 dislocation. There is no question that this is not a fixed anomaly. This needs atlantoaxial stabilization. Then we introduce another concept. Even when the facets are in alignment, presence of Chiari, presence of syrinx, presence of basilar invagination are indicators of an unstable atlantoaxial joint. You stabilize the atlantoaxial joint, the syrinx will reduce. Whether the syrinx reduces or not, the patient will dramatically improve in his clinical symptoms. So there is a retrolisthesis of C2. This is C1 over C2. This concept that even when there is no atlantodental interval disturbance, the facets have to be seen because they can indicate an unstable spine. So this basilar invagination, you see, there is no atlantodental interval disturbance. This is a clear case for foramen magnum decompression, and I used to do foramen magnum decompression even in the year 2004. But then we introduced this concept of central instability, and we have realized that foramen magnum decompression is a negative operation. It is not a case of tight posterior cranial fossa, which I introduced myself in the year 1996 in my publication. But now I am saying the issue is atlantoaxial instability and the treatment is atlantoaxial stabilization. This is another case of huge basilar invagination. There is no need to do foramen magnum decompression. This is completely an unstable craniovertebral junction. What you need to do is atlantoaxial stabilization. So you see here, this is facets are in malaligned situation. There is atlantoaxial dislocation. It is a difficult situation. You see syringomalia, huge syringomalia. There is no tight posterior cranial fossa. There is no need to do foramen magnum decompression. You see the syrinx has disappeared and the patient has remarkably improved in the clinical symptom. Even when there is no atlantodental interval disturbance, even when there is no facetal malalignment, presence of tonsillar herniation is a clear indication of unstable craniovertebral junction and merits the need for atlantoaxial, not occipitoaxial fixation. So now we have got several hundred cases of Chiari malformation and basilar invagination with bone abnormality, without bone abnormality, difficult operations, but if you can do it, you give instantly new life to these patients. So syringomalia, Chiari malformation, you see there is atlantoaxial instability even when there is no atlantodental unstable. So basilar invagination is an unstable spine and you need to do stabilization. So some years ago, I published my work with 500 cases of type A basilar invagination and 75 cases of type B basilar invagination. But now my work has tremendously increased over the years. So basilar invagination, syringomyelia, Chiari formation. So Chiari is secondary. It is protective. Basilar invagination is secondary to atlantoaxial instability. It is protective. Syringomyelia is secondary to atlantoaxial instability. It is protective. When basilar invagination is present alone, it indicates atlantoaxial instability. When syringomyelia is present alone, without basilar and without Chiari, it indicates atlantoaxial instability. When Chiari is present alone, without basilar and without syringomyelia, it indicates atlantoaxial instability and indicates the need for atlantoaxial stabilization. All kinds of foramen magnum decompression has been described, and all of you know about this. Some people open the dura, some people open the tonsil, some people open the arachnoid. But what I said was that atlantoaxial instability is the cause of Chiari malformation, and atlantoaxial fixation is the treatment. And I will show you several cases here. You see, this is atlantoaxial, this is syringomyelia Chiari malformation. There is facetal malalignment, and there is facetal fixation. If you see, the syringomyelia has reduced in the immediate postoperative to an extent, but whether the syringomyelia reduces or not, that is not the issue. This is tonsillar herniation. There is no facetal malalignment, and I do atlantoaxial fixation. You see, there is syringomyelia, there is tonsillar herniation, there is external syringomyelia, there is external syringobulbia, and there is no atlantodental interval disturbance, no facetal malalignment, and I do no decompression, I do fixation, and you see the syringomyelia has reduced in size. This is huge syringomyelia, no problem, and I do only fixation, and you see the syringomyelia has reduced, and the patient has remarkably got a new life. I say that tonsillar herniation is a protective phenomena. It is an outcome of manifest or potential atlantoaxial instability, and it is introduced by God to protect the human body. This is syringomyelia. There is no atlantodental interval disturbance, no facetal malalignment. Atlantoaxial fixation is the treatment. No problem. When there is Chiari malformation, no tight posterior cranial fossa, atlantoaxial fixation is the treatment. I will show you several cases. Now you carefully see when there is basilar invagination like this, there is no question of removing this bone. You open the joint and craniovertebral realignment is the treatment. This is preoperative. You see syringomyelia, tonsillar herniation, and this is immediate postoperative. You see reduction in the size of syrinx and tonsillar, and this is delayed further reduction in the syrinx. I will say the syrinx will reduce in 100% of patients if you do a good fixation and you do a scan after 1 year of surgery. In about 15% of patients, there will be immediate postoperative reduction without opening the dura and without doing any manipulation of the tonsils or foramen magnum. You see, this is atlantoaxial fixation, and this is immediate postoperative reduction in the size of syrinx. So this is syringomyelia, tonsillar herniation, this patient, and you see reduction. I have shown you this slide earlier. This is syringomyelia, tonsillar herniation. This slide also, I think I have shown you. This slide I have shown you earlier. I think I have, now this is the syringomyelia, tonsillar herniation, basilar invagination, facetal malalignment. You see the syringomyelia has reduced in its intensity. Again, I'm saying it is not the reduction of syrinx which is the issue. It is the patient, and the patient will get instant post-operative, as soon as recovers from anesthesia, a new life. There is no need to do any decompression because these are manifestations of an unstable spine, particularly when there is basilar invagination. Even when there is basilar invagination or no basilar invagination, presence of Chiari by itself. I will show you several other patients. So there is tonsillar herniation, there is facetal malalignment, tonsil goes up in cases, in 100% of cases. So you see there is no atlantodental interval, there is tonsillar herniation, there is reduction in the size of syrinx as you do more and more delayed scan. So after 1 year, in 100% of patients, the syrinx will reduce and the patient will slowly, gradually, and rapidly improve in the symptom. This is syringomalia. There is no basilar invagination here. There is facetal malalignment. Syringomalia reduces, and there is only atlantoaxial fixation. There is no foramen magnum decompression. This is another case of syringomalia, basilar invagination, this reduction in the size of syrinx. I am having some repetition, so you please ignore those repetitions. This is syringomalia, and the syringomalia has completely reduced, and this is atlantoaxial instability. This is syringomalia. See the reduction in the syringomalia. There is no decompression of any kind. This is syringomalia. This is reduction. There is atlantoaxial fixation. This is preoperative. There is some facetal malalignment. There is no atlantodental interval disturbance. I do atlantoaxial fixation. You see reduction in the size of syrinx. So I have got several hundred patients now with this kind of preoperative and postoperative reduction with only atlantoaxial fixation. So this is some syringomalia, and this is preoperative and reduction in the syringomalia. There is no basilar invagination here. I do only atlantoaxial fixation. There is basilar invagination, assimilation of atlas. There is syringomalia. You see reduction in the syringomalia, only atlantoaxial fixation. There is syringomalia, no atlantodental interval disturbance, no basilar invagination, facetal malalignment type 2. You see, I do atlantoaxial fixation, reduction in the size of the syrinx. So when I wrote this paper, there were several people who questioned my work and several letters to editor. In the year 2013, I wrote this article, and many of you know that there were many questions asked to me that we are doing foramen magnum decompression, our patients are improving. So there you must read the literature to see what answers I gave to many of these questions. First, the other question was whether it works when there is no craniovertebral bone abnormality. So about 5 or 6 years ago, I wrote this article, Atlantoaxial Fixation as Treatment of Chiari and Syringomalia when there was no bone abnormality, no basilar invagination and things like that. So I wrote an article with 57 cases. So there was no basilar invagination, but Chiari do only atlantoaxial fixation. This is also no basilar invagination, but there is facetal malalignment. You see the syringomalia, do atlantoaxial fixation. Syringomalia reduced quite remarkably. Syringomalia, and you see atlantoaxial instability, syringomalia reduced. There is no bone abnormality. There is no foramen magnum decompression. So I have got several cases now over the years. I have got now several international patients from all over the world who have been done there where foramen magnum decompression has been done, and they are coming to do atlantoaxial fixation, and you give new life. I have got a radio singer who was singing before, and then she lost her speech by foramen magnum decompression, and then I did foramen magnum stable atlantoaxial fixation, and I gave back her radio singing. So you see there is no basilar invagination, no real facetal malalignment. I do atlantoaxial fixation. You see many of these things I'm saying, but if you want to really identify want you to come to my department and see with your own eyes. Many of you are scientists of neurosurgeons. You are not ordinary people. You are scientists. You have to do philosophical. You cannot say, no, I don't agree, or what you don't agree. If you don't agree, you see this image if you don't agree. You see syringomalia, Chiari malformation, no problem. Not much basilar invagination. I do only fixation, and you see the syrinx gone. There is no decompression. I don't agree means what? Don't agree. You see the syringomalia, no problem. I do fixation. The question is, the issue is that these operations are not easy. When there is tonsillar herniation, when there is syringomyelia, to do atlantoaxial fixation is not an easy surgery. It can be very difficult and dangerous operation. But if you can do it, you absolutely, you see this another case, there is not real basilar invagination. See the tonsillar herniation, see the huge syringomyelia, and you see the fixation and you see the reduction in the syringe size. This is pre-op and this is post-op. There is no problem, no basilar invagination, only fixation has been done. Syringomyelia, no problem, no problem. So you see there are several cases which I'm showing you, which look very similar to each other, but the pathology is absolutely. This is the patient I did. I'm not sure if you can see, this is very immediate after some improvement in walking, but you see, this is the least that you can expect. You can expect several other miracles. So craniovertebral junction, atlantoaxial instability, there is not only short neck, there is also short head, short spine. And you see this, these are brothers, this patient has become short. So short neck, short head, short spine, and short body height are hallmarks of basilar invagination. External syrinx, I introduced this term. You see there is CSF formation outside the cord. External syringobulbia in the presence of chronic atlantoaxial dislocation. This suggests chronic atlantoaxial instability and suggests the need for atlantoaxial stabilization. So there is external syrinx and internal syrinx. There is syringomyelia, internal syrinx. If you go and puncture the syrinx here, you will kill the person. If you puncture the syrinx here, you will devastate the person. What the person needs is atlantoaxial stabilization. External syringomyelia, I wrote this paper with my daughter where I introduced her to the subject of neurosurgery, can be present in long-standing foramen magnum tumors. You see there is a tumor and there is excessive amount of CSF here, excessive amount of CSF. So you can have external syringomyelia and you absolutely know that this is a benign tumor, foramen magnum tumor, benign, present Chiari malformation presenting with sixth nerve weakness. You do fixation and the sixth nerve recovers. You see this is not moving and now it is moving. In the immediate post-operative period, there is a possibility. I have got now at least 100 patients, if not more, where foramen magnum decompression has been done when the patient comes to me. And there are many lawsuits now because the doctor has not told about fixation. I have 2 lawsuits facing some patients who were done foramen magnum decompression and the doctor never told them about fixation and they have sued the doctor. So you must, at least if you are doing foramen magnum decompression, you must tell that somebody is doing only fixation for this because you can be in serious trouble if you don't tell them. So foramen magnum decompression was done, syringomyelia, I do fixation and the syringomyelia regresses after surgery. This was another patient who has undergone 13 operations. Ventriculoperitoneal shunt, third ventriculoperitoneal shunt, syringosubarachnoid shunt, foramen magnum decompression for 4 times. And this gentleman is an engineer in IIT, in a very prestigious institution of India. And then I do atlantoaxial fixation. This was another patient where several operations has been done. You see there is a shunt here and there is foramen magnum decompression, several operations. And then I do atlantoaxial fixation. You see the syrinx disappears and this patient had come in this devastation. There is tube in the nose, there is tube urinary catheter, and there are various catheters all over the place. And you see the serene smile on his face as he was being discharged from the hospital. Here catheter is still there, but now there is no catheter and this person, an engineer, has come back to his engineering life. This is another patient where foramen magnum, this was the singer I was saying, where some kind of screw fixation was done, but this was not a stable fixation. I removed this implant, I opened the joint, introduced screws directly into this joint, and this patient who was a radio singer before operation, before the first operation, is now back into radio singing. So I have got now, see, when you have foramen magnum decompression is already done, then what you will do if the patient has not improved? I am saying foramen magnum decompression is a negative operation. Do not do foramen magnum decompression. And now, as I have mentioned to you, I have got at least 100 cases, if not more. Pediatric patient, I was, when I wrote this paper in 2013, many pediatric neurosurgeons from the world said, no, 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 this does not work in pediatric patient. Then I wrote my series in pediatric groups. In 33, now I have got at least 100 patients of pediatric age group patients where I have done atlantoaxial fixation with dramatic results. You see this patient, syringomalia gone, and there is Chiari and syrinx, and this patient remarkably, this is the patient, and you see this patient was hardly able to walk before operation, and this is after 3 months when he came to me, and now he's standing with me in a very fantastic fashion. So this is another child with syringomalia and Chiari treated with only fixation. You see syringomalia child are treated with only fixation, and I have got several patients with these kind of problems. And this is tonsillar herniation with facetal malalignment. And this is the patient, adult patient. You see, little bit walking in a very difficult way. And now she's walking much better, you see. And this is in a very quick, immediate post-operative period. And she's talking in Indian language. You may not understand, but if you see, she can now run. And I can tell you, without any hesitation, without any doubt, that you do fixation, 100% of times you have improvement and 100% clinical outcome. Foramen magnum decompression, we were ourselves doing. This is another patient. You see, this patient was having a very hesitant gait. And now, if you see, he's having, he's talking in my language, but I don't want to introduce that language to you. I have introduced a beautiful technique to you, and that is what you should, is more important when we are talking science. C2-3 fusion, assimilation of atlas are manifestations of atlantoaxial instability. When there is C2-3 fusion and there is disc, you do atlantoaxial fixation. There is no need to do C2-3 and C3-4 and C5 fixation, which I had described. But now I am saying that C2-3 is an evidence of atlantoaxial instability. You do atlantoaxial stabilization. You see there is a cord compression here. But this is secondary. Primary is this problem. You do atlantoaxial fixation. Syringomalia when present alone without Chiari. When Chiari is present alone without syringomalia, you have to do atlantoaxial fixation. And I wrote this article several years ago. That, and you see the syrinx has gone. This is idiopathic syrinx, and many people used to call it idiopathic syrinx and do shunts and all those things. I am telling you, there is an opportunity for you to give absolutely new life to these patients. You have this concept of atlantoaxial instability. When there is kyphoscoliosis and syringomalia, then what you do? There is a big confusion in the literature whether to treat syrinx first or Chiari first or kyphoscoliosis first. I am saying you don't treat Chiari, don't treat syrinx. You do atlantoaxial fixation. The Chiari will be finished, the syringomalia will be finished, and the kyphosis will be finished. So this is the kyphosis. I am saying today, if you go to orthopedic surgeon, there will be 200 screws and 1 kilometer long rod. I am saying in 100% of patients, 100% of patients with this kind of kyphoscoliosis, the problem is not here. The problem is at the craniovertebral junction. You do atlantoaxial fixation and you do good new life. So spinal kyphosis is due to secondary manifestation of atlantoaxial instability, and you have immediate postoperative recovery. You see this kyphoscoliosis. There is nothing done to the spine, only fixation. And within 1 or 2 months after surgery, you see the spine has become straight and the spine has become long. And the motor evoked potentials recover during operation. There is no question and there is no doubt. So my dear friends, Keep this in mind. No need to argue. This concept is made. This concept is done. Central or axial, atlantoaxial instability without any other manifestation like no bifid, no chiari, no syrinx, no basilar invagination can be identified as a discrete pathological issue and can cause myelopathy. I reported 5 cases. Now I have at least 50 cases, and I am going to report very soon my outcome. You see, there is no compression, but bifid is there. It indicates central atlantoaxial instability. There is external syringomyelia. It indicates atlantoaxial instability. There is syringomyelia. It indicates atlantoaxial instability. There is C1 fusion, indicates atlantoaxial instability. Some rotatory dislocation indicates atlantoaxial instability. So all these are manifestations of atlantoaxial instability. Hirayama disease, nobody in the world knows how to treat. Foramen magnum decompression has become a historical operation. Never I do it for last 10 years at least, no foramen magnum decompression. I want to rapidly go into craniovertebral junction instability due to degenerative arthritis is very common. Atlantoaxial joint is the most mobile joint of the body. Atlantoaxial degenerative arthritis is the most common instability or degeneration of the whole body. C5, C6, C4, 5 instability is there, but atlantoaxial instability due to vertical spinal instability, this buckling of the posterior longitudinal ligament, osteophyte formation, reduction in the joint space are all secondary manifestation. Osteophyte formation in the apical ligament indicates the presence of an unstable atlantoaxial joint. Bone formation in the apical ligament is a manifestation of unstable spine. You do atlantoaxial fixation and you see the magic. Bone formation in the apical ligament, bone formation, osteophytes here and there, you do fixation, that is the treatment. These bone formations indicate the presence of an unstable spine. OPLL presence in this region is a clear manifestation of an unstable atlantoaxial joint. You do atlantoaxial stabilization. Retroodontoid pseudotumor is a manifestation of this osteophyte of the craniovertebral junction. It indicates the presence of unstable craniovertebral junction. No need to do decompression, anterior or posterior. It indicates the need for atlantoaxial stabilization, and you see the magic. So we introduced this magic in 2004 in a Japanese journal, and there is no question it has created a revolution in the field of craniovertebral junction. Retroodontoid pseudotumor is a manifestation of unstable atlantoaxial joint. Atlantoaxial fixation is the treatment. Retroodontoid pseudotumor should never be touched. You do atlantoaxial fixation. So there are several cases where we have got this kind of cyst formation, and we also notice this cyst, you do atlantoaxial fixation, there can be a possibility of immediate postoperative regression of this cyst. You see this huge cyst, there is no need to come and remove this cyst. This is unstable spine. You do fixation. After 3 months of surgery, this cyst is completely disappeared. This is osteophyte formation, cyst formation, retroodontoid pseudotumors are manifestations of unstable atlantoaxial joint. No need to touch the subaxial spine. They are all secondary. Pannus, this pannus pseudotumor behind the retroodontoid is a manifestation of vertical instability. This pannus does not need to be treated. You do atlantoaxial fixation, the pannus disappears. So this pannus disappears by distraction of the facet, and this instability disappears by distraction of the facet. So for rheumatoid arthritis, there is no need to do any kind of decompression. In cervical spondylotic myelopathy, we never talk of atlantoaxial instability. I have to say without hesitation that atlantoaxial instability is very frequently present when there is multi-level spinal degeneration. And OPLL and cervical spondylosis are manifestations of unstable craniovertebral junction and subaxial spine. you see there is instability here. I have talked in Juha symposium earlier on this, so I don't want to talk much, but I just want to introduce that atlantoaxial instability can be present in multi-level spinal degeneration. This is central instability. You have to do atlantoaxial stabilization. You cannot ignore this atlantoaxial instability. When there is severe myelopathy, there is almost always the presence of atlantoaxial instability, and you have to treat atlantoaxial stabilization. You have to do. So we mentioned that in OPLL, there is no need to decompress either from front or from behind. And in OPLL, you see there is trans-cervical decompression and posterior decompression are both unnecessary operation. The treatment is only stabilization. And you please read this. I have already discussed this issue in Juha symposium. I don't want to repeat. But atlantoaxial instability is very commonly associated with OPLL and with degenerative spine. You have to treat. So ossification of OPLL, the role of craniovertebral junction and spinal instability, you please read my articles on these subjects. And I have suggested that there is no need for decompression. Atlantoaxial and subaxial fixation is the treatment. You see, this patient has not undergone any kind of decompression. This has undergone only fixation. So atlantoaxial and subaxial fixation, can it revolutionize the treatment of cervical myelopathy related to OPLL? Absolutely. This kyphosis is secondary to atlantoaxial instability in this case. You treat atlantoaxial dislocation and kyphosis is finished. When there is kyphosis with central instability, you have to include fixation construct, atlantoaxial joint in the fixation construct. When there is lower cervical kyphosis, there is lower cervical instability, and you have to do lower cervical fixation. You must read my article on this cervical kyphosis. So Hirayama disease, similarly, nobody knows what is the treatment. We have identified that atlantoaxial and subaxial instability is the cause of Hirayama disease. So my question to you is Chiari good or bad? Is it formation or malformation? No question in my mind. And all those who are listening to my presentation should have no questions in their own minds that Chiari is good for the patient. It is a formation and not a malformation. We should change this name instantly and without any delay. So basilar invagination, syringomyelia, and Chiari malformation are not primary problems. Atlantoaxial instability is the cause, and atlantoaxial stabilization is the treatment. They are nature's protective formation to stall or delay the effects of instability. So atlantoaxial stabilization is the treatment. Occipital fixation is never necessary. Foramen magnum decompression is counterproductive. Transoral and transnasal decompressive surgeries are completely historical. So thank you very much, my dear friends. I hope you have enjoyed this presentation, which was a summary of my lifetime work. And I am sure those who will be in this business of craniovertebral junction would have got some new insights in the subject. Thank you very much, Juha. And you have given me this opportunity to introduce this very big subject of our interest. And this is not of our interest, but it is absolutely of the interest of our patients, where we have the power to give new life. Thank you very much.
Thank you very much for this magnificent.
You are muted. You are.
Oh, he's got it. He's got it.
Thank you very much for this passionate.
No, you cannot be heard.
No, we can hear him, Atul. I don't know what's going on. Everyone else can hear Juha, right? Yeah, we can hear him fine.
Sorry.
Can you hear me now?
Yeah, we can hear you fine.
Can you hear me now?
Yes.
Okay.
Yes.
Thank you very much for this passionate, magnificent lecture. There's a huge number of information in these thousands of patients. So my comment is that, do you have a database on these cases, and how is your follow-up? I think when you are dealing with such a big number of the patients, you might benefit from database.
Yes, yes, we have a huge database, and my own department has been, you see, we have been treating, my own department, we have been treating for 1960s. We are having database of over 15,000 patients or more now. 15,000 patients since 1960s. We are having a database, and complete all clinical information is included in that database, Juha. And
Okay,
I
yeah.
want,
This
you
is
know,
hospital database,
yes, yes,
not your
hospital.
own database.
No, hospital database, yeah.
Yeah, this is different what I mean. So, for example, if you would make a database on this posterior stabilization patients, so you would have different variables included there. So don't.
I also want Juha, I want, there are
When we were dealing with 18,000, more than 18,000 cerebral aneurysms, we noted we cannot write anything about these patients if we don't have an accurate database, and so this is different from the hospital database. Maybe the younger people might do it for you in your own cases, because you will give a big legacy for the whole world with your information on the neurosurgery, so it might be more accurate. But of course, you have been writing so profusely on these cases, so certainly it is not my thinking that I don't believe, but I just think that it might be even more accurate when you one day publish all your series, more than 3,000 or 4,000 cases of this disease. So my another remark is that I noted in one case you didn't take the hair of the beautiful Indian hair of the patient, but in many cases they lost their hair. So I think in this posterior midline operation you don't have to shave the hair.
Yeah, you don't have to shave.
How is your policy nowadays?
No, I don't shave the head, but I have to shave the back of the head. And also I use traction, where I put the traction tongs here, traction. So, sometimes with the hair, you can push the hair inside, or you make a small, remove some hair from here. So, this is a, hair can be, of course, what is important is, you know what, I can tell you, that this is such a beautiful operation, such a wonderful operation, that all the young people at least should know this technique, and they should have to learn. They cannot just, I don't want to do and I don't want to do. This is not the attitude of a neurosurgeon. Nobody can say it is complex, I don't want to do. It is not correct. You have to learn, and you have to learn. And I see many young people in the audience, and I want to ask them whether you want to learn this technique. If you want to learn, put yes on the screen, and I will be happy to see that yes from you.
Dr.
Okay,
Gandhi,
when the world opens, then I will come to Mumbai to learn this technique
Okay.
for some years.
Yes, you are still young.
Thank you.
I know you are young, and you have to come.
Okay.
Thank you, Professor Gore, for your fascinating presentation. And I watched your presentation for several times, and now I understand your concept more and more deeply. So I think you are correct. Sometimes we did the posterior decompression for the caries malformation. That's not correct. I think you are correct. You fix joints, and but you demonstrated a lot of cases that do you calculate the angle that the two screws, between the two screws before the surgery, you making the surgical plan?
No, it is not. You know, it is important. Your question is very correct that you should know exactly where the angle has to be there and where you have to insert the screw. But because, you know, the anatomy is so variable, the anatomy is so different, you know, it is not that you want to put the screw only at 60 degrees. You have to change during operation and you have to see with your, you know, eyes and then introduce the screw under vision. So it is very important because there are, you know, I have not talked about the complications which can happen. And there can be very serious complications. You can damage the vertebral artery. You can have various complications. Maybe in the next lecture of UASIM Grand Round, I may talk of only complications, but there are not too many complications. I must say that the complications can be very, very few and the results can be outstanding. Outstanding neurological improvement, outstanding clinical improvement, complete change in the health of the person. So complications there are there in every operation. You do glioma surgery, there can be complication. You do bypass, you can have a complication. You do burr you can have a complication. Complications can be there in more complex surgery. But if you know this technique properly, there can be zero complication and then can be beautiful outcome. I have, you know, done all kinds of neurosurgery, skull base, vascular, this and that. But I can only tell you that the results of this operation, no other operation in our subject can match the results of a beautiful atlantoaxial fixation. Juha.
Yeah, sometimes you mentioned that you made the 3D model for the patients. So how often you use this 3D model?
3D model is a very fantastic new investigation. You will be happy to know that I do 3D model reconstruction for AVMs in many of my cases. Almost all of my AVMs, I showed you the other day on AVM surgery, that I do models. Similarly, for craniovertebral junction, not for a regular case, but a very complex case, I will be happy to have a model with me.
How often?
So not, you know, if I'm doing 20 cases, maybe 3 or 4 or 5, not more than that.
Okay.
But you know what? Now I am getting cases from all over the world with very complex cases, very complex, with no neck or very short neck or complex neck and complex basilar invagination. So that is my recent thing, that I am getting very, very complex cases.
Yeah. You mentioned that you will remove some muscle from posterior. So is there any atrophy from the backside?
See, when there is atlantoaxial dislocation, you have to do atlantoaxial fixation.
Yeah.
And you will have arthrodesis or fusion of atlantoaxial joint. If the muscles are active, you see, if the muscles are active, they will keep on pulling the implant and they can disturb the implant and they can break the implant. So you have to always remove the muscles. If you do not remove the muscles, your implant can fail. But the thing is, you lose your rotation movement, you lose your atlantoaxial movement, but rest of the spine, you see, rest of the neck can work. So there is hardly any effect on the movements of the neck. And many a times you will not even notice that there are abnormal movements. But there is some restriction, all right, in this case.
So you only remove the muscles attached to the C2?
C2, yes.
Okay.
Or C2 spinous process, which is the largest spinous process of the whole spine.
Okay, thank you.
We had a
Some
question
other
from the.
comments, questions?
Go ahead.
Victor Hugo?
Victor.
Hello, dear friend, Atul
Yes.
Go. Excellent,
Yes.
excellent lecture, impressive. We should see the lecture again and again and again, because we can learn so much about this. I think surgical anatomy of the craniovertebral junction is very complex. So I am doing some models to show this craniovertebral junction, also with the muscles that we have to work with them, and also the vertebral arteries, the nerves, and this is a copy of a real bone. This is a copy made in resin, and we can mobilize the articulations in here. So I think for young brain surgeons, it's very important to know the exact anatomy of the craniovertebral junction, especially the vertebral arteries and articulations in these bones involved in this complex anatomy. So this is for beginners, of course, and I think before you do one surgery like this, you should know exactly the anatomy. Thanks for your impressive lecture and congratulations.
You know, Victor is a world-renowned neuroanatomist. You know, Victor, can you put your email in the chat? Maybe some people want to get a hold of you, okay?
Victor has done some remarkable work on anatomy, on introduction of dyes in the spinal cord and spinal arteries and cranial arteries and all kinds of arteries. He has shown some beautiful work. So like Victor is always giving me some nice compliments, I have to give Victor all the compliments that I have, that his beautiful work should be shown. John, you are correct that Victor is one of the foremost neurosurgical anatomists in the world, without any doubt.
Could you put your email in there?
Yes.
Okay, so people can get a hold of you.
Thank you, Dr. Atulgol. Thanks, Dr. Juha. These rounds in surgical anatomy and neurosurgical procedures is really useful for all the brain surgeons around the world. Thank you so much, Dr. Binshu, Dr. Takashi Kon. Thank you to all of you.
Some other comments?
Okay,
It was
Verdad,
very convincing.
Oh, go ahead. I'm sorry.
It was very convincing long lecture. So I think we should save this lecture so that it can be seen also in future.
Okay.
Yeah. We all recorded
very
in the
important
WeChat.
Yeah.
So every
Very
time
important.
Professor Atulgol's presentation, there would be around 2,000 audience every time.
That's great.
Yeah.
That's great.
Yeah.
That's great. Thank you.
Mhm.
And thank you for Ben for translating to the Chinese audience. And thank you, Tashi. Tashi, want to introduce yourself, Tashi? Tosh, can you
I'm Dr. Kon, Takashi Kon from Tokyo, Japan, and live in Showa University. Thank you, Dr. Gold, very informative lectures every time. So I'm so impressed and I learned a lot. So I would disperse to advertise to the more and more Japanese residents, and try to attend and try to study and continue for translation. Thank you.
Yeah, we have to thank Ben and Tashi for giving accurate translations because they're both neurosurgeons, and we thank them for that. And thank you, Juha. Do you have a topic for next week?
Thank you very much.
Yeah,
Thank
we'll also
Arthur.
thank Dr. Liao Yujing. Yeah, sometimes he helps us to translate the presentations.
Very good. Juha, do you have a topic for next week yet?
We wait for it. So we will inform in the beginning of next week. Yeah.
Okay, very good.
Okay.
Okay, thanks, Atul. And Atul's lecturing right now at another conference.
Thank you.
Let me quickly show that. Atul, let me get her. Just give me a second.
Abdul Rahim is here. You want to make any comment, Abdul, from Turkey?
Okay, go ahead. Yeah, go ahead. If you want to speak, Abdul, you have anything to say? Perhaps not. Just give me. Go ahead.
How are you?
Very good, Abdul.
Okay.
Thank you very much for your wonderful presentation. Thank you, sir.
Thank you, Abdul. Thank you.
Okay, then, we'll see everyone next week.
Okay, thank you very much.